Welcome to Ask Dr. Antoine, coming to you live from the Trinidad and Tobago Diabetes Association, or the Diabetes Association of Trinidad and Tobago at the Center of Excellence in Trinidad. We are truly honored today to have with us Professor Felicia Hill Briggs from Baltimore. Professor Hill Briggs is a professor and faculty of general internal medicine at Johns Hopkins Medical Institute and Johns Hopkins School of Medicine. So, Professor Hill Briggs, thank you for coming all the way to Trinidad to be the featured speaker of the Diabetes Association of Trinidad and Tobago Expo 2017.
Well, thank you so much, Dr. Antoine. It is a pleasure for me to be here, both for the Diabetes Association of Trinidad and Tobago's event, and also to be able to talk with you. So I appreciate your inviting me on.
Well, we're truly honored to have you. But the funny thing is, we're going to keep this lively.
Yes.
Right? And you said my name is Dr. Antoine, and rarely do I hear that in Trinidad. I usually hear Antoine. But I like that too, because my family calls me Gerard Antoine when I'm in the States. Right? So,
I see.
but now you're a professor at Johns Hopkins School of Medicine.
Mm-hmm.
So what does that mean? What do you do exactly?
Mm-hmm.
And I know we're going to make you Trinidadian by proxy,
Yes.
because you're married to a Trinidadian.
That's right.
So
I am Trinidadian by marriage.
by marriage, right? So that's awesome. So now tell me, what does a professor of internal medicine at Johns Hopkins School of Medicine do, and why are you here? And I know you're also, which I neglected to say, you are the president-elect of the American Diabetes Association. That is a phenomenal accomplishment.
Okay.
Congratulations.
Well, thank you so much. So first of all, let me talk a bit about Johns Hopkins. And I have to put the S on it because often people leave that S off. Johns Hopkins, Johns with the S was actually the first name of the founder of the Johns Hopkins School of Medicine. And so what do I do as a professor? I would say I am unusual as a professor, particularly in general internal medicine. I'm unusual for one reason because I have a PhD and I am a clinical psychologist and neuropsychologist by training. Most of the faculty in general internal medicine are medical doctors, primary care physicians. As a professor, I get to do many things. So I do research, and my research is really in chronic diseases and diabetes and the impact of diabetes, not only on the individual who has the disease and their families, but also the impact that diabetes has on the entire population. And so I'm here largely with the expertise that I use at Johns Hopkins in diabetes and how we can help address diabetes so that people with diabetes can live longer, better lives, and so that we as a nation and Trinidad as a nation will not have to suffer the types of consequences from diabetes that we are really seeing globally. And so my work is really about how do we improve outcomes for people with diabetes. And now, more and more, we're really focused on how do we prevent type 2 diabetes in the first place in order to stop the trajectory.
No, Professor Hill Briggs, I've noticed, before this segment started, you told me you are a diabetic.
That's right.
Now, how has that impacted your life and your family's life?
So I have type 1 diabetes. I was diagnosed at age 9, and so I have now lived 42 years, now you'll know my age, over 42 years of successful living with type 1 diabetes. At the time that I was diagnosed, my primary care doctor, my pediatrician, and no one in my pediatrician's practice had ever seen a child with diabetes. They'd never treated type 1 diabetes, and so it was very strange to be diagnosed with this disease that my doctors didn't even really know much about. And so having type 1 diabetes has impacted everything in my life. I have grown up knowing this disease as a part of my everyday existence. Very challenging for my family. I have an older sister, and for my parents when when they were told the diagnosis. And in fact, at the time that I was diagnosed, the lifespan was much, much shorter, particularly for type 1 diabetes. And my parents were told that I likely wouldn't live to see age 40. And so you can imagine what that does to a family and to a person to think that you would not even be able to live a normal lifespan. And so, not surprisingly, as an adult, I decided to turn my focus and my professional activities toward diabetes and improving not only my own knowledge and understanding of the disease, but helping to do that for others.
So now, Professor Hill-Briggs, you've been honored with this responsibility to be the president, now that you're the president-elect of the American Diabetes Association. Now, that comes with a tremendous responsibility. What difference do you think you can make? What do you plan to bring to the playing field based on your experience with diabetes? And now there are a lot of questions. Now that I'm practicing in Trinidad, and I want to hear your take on it, as far as what do you plan to bring to the table, to the playing field that's going to change the diabetic's life?
Right. So, as you said, I'm president-elect. The American Diabetes Association has two scientific divisions, science and medicine and healthcare and education. I'm president-elect of healthcare and education. And just as the title implies, I am honored to be able to have tremendous responsibility in the American Diabetes Association's direction by way of how we provide medical care and health care to people with diabetes, how we train our healthcare professionals, not only physicians and endocrinologists, but how we train nurses and diabetes educators and others who are involved in the care of people with diabetes. And we help drive the agenda nationally and globally even on how we support people with diabetes. What in particular I believe I bring to the table is a focus not only on reinforcing what we already know and what we've already accomplished as an American Diabetes Association by way of our educational programs and trainings and how we're able to, through our call center, for example, respond to the needs of individuals and our advocacy. But my particular focus and interest during my tenure as president-elect and president is on social determinants of health and how social determinants impact people with diabetes above and beyond the tremendous impact diabetes already has. And so my own work personally, as a researcher and as a clinician, practicing as a behavioral medicine specialist, has been with high-risk communities. And in the United States, our high-risk communities are those communities that are racial and ethnic minority groups, people who are in poverty or lower socioeconomic status groups. And so, as you well know, resources, the ability to prioritize health over other types of challenges in one's life make diabetes a particularly difficult disease. And so nationally, through the American Diabetes Association, we will be tackling social determinants of health in the ways that we traditionally do, which is ADA, of course, has its standards of care and its practice guidelines. Well, similarly, we are developing a position statement on best approaches, evidence-based ways of mitigating the social determinants of health and how they're impacting our highest risk communities.
Now, this is a Trini question, because I get this every day, almost every day.
Yes.
My mother has diabetes. My father has diabetes. Am I going to have diabetes?
Right, right. And so we certainly know that if you have a family history of diabetes, your risk for diabetes is elevated. And so you certainly might develop diabetes, but you are not destined to develop diabetes. And so something that's very, very important to do when you have a family history that goes way, way back, generations, is to be aware of what those risk factors are for the disease that you can actually do something about. So you can't do something about your genetics and who you
Absolutely.
were born to.
Well, actually, different parents.
Right. You don't get to go back and choose different parents who've been healthy and grandparents who've never had a chronic
Rich
condition.
parents.
Yes, right. So you're here, and so you want to focus on the things that are modifiable. The good thing about type 2 diabetes is that there are risk factors that you can change, and we also know that if you start early developing those healthy habits, you can prevent diabetes. And so those risk factors that you can change have to do with whether you are physically active. We call sedentary lifestyle. That's when you don't move, you're not doing much physical activity or exercise. We know that having a sedentary lifestyle, particularly if you already have a family history of diabetes, puts you more at risk. We know that if you are overweight or obese, particularly when you have a family history of diabetes, it puts you more at risk. And so what we focus on for people who really are concerned about the likelihood of their developing diabetes, it's as early as possible, understanding what to modify, how much, in what way, and starting routine lives that are practicing these healthier habits.
So there are some conspiracy theories out there. In Trinidad and Tobago, it's the flour conspiracy theory, because our diet is primarily made up of flour. You wake up in the morning, you have a doubles. For lunch, I'm having a roti. For dinner, I'm having some bush-up shut and some real good, and it's hard to get away from the flour. Now, I am not one of those I could be, and sometimes I am in the flour conspiracy theory. Now, we're going to clear this up once and for all, because you're the scientist, and you're dealing with this on a daily basis.
Yes.
What's the deal with the flour in our diets?
Well, first of all, I'll preface this with, I am not a nutritionist. However, certainly as a behavioral medicine specialist, the two behaviors we focus on a great deal are helping people develop the healthy nutritional habits and stick with eating healthy and physical activity. And so by way of nutrition, what works, what allows people to be able to develop and maintain lifelong healthier eating habits is being able to eat a balanced diet. We often find that when people do restriction, sole restriction, it becomes much more difficult for them to maintain their eating habits. And so the American Diabetes Association does not prohibit flour being a part of a diet for someone who has diabetes. However, everything in moderation.
Absolutely.
There are limits to how much carbohydrate should be consumed, and flour will count as a carbohydrate. And depending on how that flour is used, what the food is, how much of it is in a particular preparation of the food, you may be very limited in how much of it you'll be able to consume. And sometimes it's a matter of really limiting how often you consume a food. It's not so much eliminating it, but this isn't something you should consume more than once a week sometimes.
Yes.
Or
Well, we have to have our doubles in Trinidad and our roti. We have to get that fixed as soon as you get off the plane.
I had doubles this morning.
So now the other question is, right? Now, patients always ask me, they don't like taking tablets, and Trinidad is tablets.
Yes.
Can I ever get off these medications? And I know as a clinician that you can. And patients, they're looking for that opportunity to get off you know, the tablets.
Right.
What do you see in your practice, and how do you go about explaining to patients if you're sitting here, if I'm the patient out there?
So every individual is different. And so there isn't a one answer that fits for every person. However, what we do know is that it's not only the medication that's working to help maintain or bring blood sugars closer to normal or maintain normal blood sugars. And so for people who really would like to be able to eliminate their tablets, we recommend that they start really relying and increasing their adherence to behaviors such as the healthier eating and getting more physical activity. Those behaviors,
Behavioral changes.
those behaviors singly and certainly in combination do help to control blood sugar levels. Now, it's important that you consult with your own doctor.
Absolutely.
Because your doctor knows your body and what may be possible for you. And so often when you meet with diabetes educators, they are going to take a very complete history that goes into the behavioral changes, such as how often you exercise and what you're eating, and they can help you make modifications that should result in your being able to see better blood sugar control. What physicians often want to do is they'd like to see your blood sugar levels coming closer to normal with your change in behaviors. And the vast majority of physicians, if they see the blood sugars coming closer to normal with your behavioral changes, they will then start to modify your medications. They would be very loath, perhaps, to cut back on the medications before you start the behavior change. But by doing the behavior change, they can look at how effective it is, what the rate of decrease is in your blood sugars, so that they can make adjustments. Often they might start to wean as opposed to stopping medications
Absolutely.
altogether.
And that's what they want. They want you
cut
it's like
back.
they
Absolutely.
they just want to stop.
That's right. That's right. And we see that very often. And certainly in the research we do, where again, we're working with very high risk patients and communities, and I solely do behavioral interventions. And at the end of our trials, what we do see is many people have been able to cut back significantly on their medications, sometimes even stop their medications.
So now, you were involved with the 2012 Johns Hopkins collaboration with the Ministry of Health and a slew of other organizations here in Trinidad
Yes.
with the diabetes study. Now, one, what was the objective of that collaboration? And two, what did you guys really find? And could that be extrapolated? Could we use those numbers
Right.
for the entire country, including Tobago?
Right. So that's a great question. So the collaboration that you're speaking of was a collaboration between Johns Hopkins Medicine International, the Ministry of Health. It also, as you said, involves several other partners, including at that time the Ministry of Science and Tertiary Education, and there were several components to that. I was involved in the diabetes component, so I'll speak to that one. We developed a diabetes outreach program. The diabetes outreach program had two overarching aims. One was to help to improve clinical care for people with diabetes by working with primary care providers to, within their practice sites, be able to do such things as point-of-care testing to have hemoglobin A1C and cholesterol values immediately available to them, so that when they saw their patients, they could make adjustments right then and there, as well as their blood pressure monitoring. And that clinical component of the program also trained nurses and other ancillary healthcare personnel to be certified diabetes educators. And the goal there was to produce a workforce of people who could then, within primary care and within the public health sector, deliver evidence-based diabetes self-management training and education to patients and their families. The other large aim of the Diabetes Outreach Program was research, and I directed the Diabetes Research Program for the initiative. And there, from meetings with the Ministry of Health and with researchers at the University of the West Indies here, we identified 3 priority research questions that we were able to conduct studies on during the time we were here. The first was to be able to get some countrywide epidemiological data on diabetes and its complications. Fortunately, the PAHO STEPS survey was to be administered, and with that STEPS survey, there were questions and samples taken in order to start looking at prevalence rates of diabetes and various complications. The second priority study was to understand the challenge of behavior change in people with diabetes. And so there we wanted to focus on one of the public health centers. We did the Penal Health Center. We were, because of the large prevalence of diabetes there. And we did one of the types of structured clinical interviews that we do in the States when we want to implement new programming within our healthcare systems. And there we wanted to understand rates of depression in people with diabetes, their self-reported barriers to taking their medications and physical activity and eating healthy and all the things we've been talking about today, and self-monitoring. And we wanted to look at whether there's a way to organize the patient's visit to the clinic to collect key behavioral indicators that would help inform the physician about these various things that would no doubt interfere with diabetes. And then the third study was really targeting youth. We partnered with the Trinidad and Tobago Olympic Committee. The committee was in the Deep South providing physical activity education and monitoring, and we were in primary schools. We were able to work with them to get prevalence rates of overweight and obesity in primary school children in the rural areas. We found, unfortunately, that the rates of overweight and obesity were higher here than in the United States, which is very hard to imagine.
I can imagine that.
Yeah.
Yeah. So now, when I reviewed one of those studies, and I'll tell you what I found reading what one of the studies showed, that only 1% of that population that you guys did the research on did self-monitoring of their glucose. And 33% of those patients did not even remembered having an A1C drawn. And in my private practice, I think it's just the opposite. I think more patients monitor their glucose with finger sticks, and almost no one knows what an A1C is.
Yes.
And I
Yes.
will truly believe that we can fix that. Because most patients don't get when they go to the hospital, the public system, the doctor will either tell them your A1C is good, bad, better, or is
Yes.
horrific. But they don't give them anything in writing. It's like a police officer
Yes.
stopping you for a ticket, and they don't say, hey, you've been speeding,
Yes.
and they let you go. Show up in court on a specific date. We need to change that. People need to know what their A1Cs, what that is.
Right.
And now, what are your recommendations, and what strategies do you plan to employ to educate patients on knowing what their A1C is?
Yes. I think some of the challenges here with knowing your A1C are somewhat different than the challenges in the States. In the States, we probably 5 to 7 years ago, there was a major campaign about know your numbers. And we have found when we do national surveying that now people know what people with diabetes know what an A1C is, or hemoglobin A1C. They may not know exactly what the number should be, but they know what it is, and that it's a way to estimate what their blood sugar control has been over the prior 3 months.
And if I may interrupt for a second, can you just tell us what just for those who, if you're watching,
Right.
if you're watching and you don't know what your A1C is, if you can tell us what
Right.
an A1C is.
Well, here's the rub. This is the challenge in Trinidad. In the United States, we have a standardized hemoglobin A1C. And so no matter what lab you go to in the United States, no matter what state you're in, when the number comes back, it has an absolute value meaning. That is, we know that the number 7.0, and so the American Diabetes Association recommends less than 7.0 as a target for hemoglobin A1Cs in people with diabetes. So in the United States, no matter where you go, that 7.0 has meaning. It means a certain level of blood sugar control because we use what's called a standardized hemoglobin A1C assay. Here in Trinidad, and this was one of the challenges we faced when we were here with our project with Johns Hopkins, labs have different standardization ranges. And so for the person here in Trinidad, it depends on what lab they go to and what that lab provides by way of what the normal range is for their lab. And so it can get very confusing for patients because if they happened to go to two different labs, let's say one time they went to lab, a hospital lab, and then the next time they went to a lab in a clinic somewhere else, even if their blood sugar was equally controlled, they may have completely different hemoglobin A1C numbers because the labs themselves have different standardized ranges. And so here it's hard to say, this is the target number, and if you are at or below this number, your hemoglobin A1C is good, and above this it's high. Not here. It depends on the lab you go to. So maybe the most important thing a person with diabetes can do here is when they get their A1Cs drawn and they talk to their doctor and their doctor tells them it was fine or it was good, they need to write down two things: what the actual A1C number was and what that range is from the lab they went to. And the good thing is when the number is given, the A1C, the labs also provide their standardization range, usually right next to it. That way, the person with diabetes has some context for what that number means when they got it from that lab.
So in my practice, I use multiple labs. So, and they always have the numbers next to it. So again, the expense comes up, the cost of the test. So most times, the patient in the public system will not get something in writing, because then that becomes expensive.
Right.
And then we can obviously know why,
Yep.
but at least they can write it down.
Right.
And most times, the physician just doesn't have the time, right? So I am very biased with this.
Yes.
Nurse practitioners and nurses, they're at the best at educating, because educating patients about this, right? So I truly believe if I allow my nurse and my nurse practitioners to spend time with my patients, they do way better at this than I do. So we're going to take some time and either ask some questions and to pick Dr. Hill Briggs' mind and from the audience, and we will roll with that. Welcome back to Ask Dr. Antoine. We're here honored to be here with Professor Felicia Hill Briggs, Professor of General Internal Medicine, Johns Hopkins School of Medicine, visiting us here from Baltimore, and we're live at the Diabetes Association of Trinidad and Tobago Expo 2017. And we do have a question, and this question is...
Right. Professor Hill Briggs, so nice to meet you. I had a question about the ADA's role in helping the Caribbean with amputations. Obviously, that's an area that I'm very concerned about. There are lots of groups, such as my group, doing things to help educate, but does the ADA have a plan to assist the Caribbean in lowering amputations? Is it educational? Is it funding? How does the ADA, looking at the problems happening in the Caribbean, how do they view that, and what resources are available?
Well, thank you for your question. I certainly agree with you about the tremendous problem of amputations here in the Caribbean. And I have to say, amputations are also, of course, a concern for us in the States. The American Diabetes Association, I don't think, has a specific partnership with the Caribbean focused on amputations. What we are doing, though, is there is, as you know, in our standards of care, we address risk factors for amputations. We have CME activities because we think the greatest need is to help both the providers themselves catch the risk factors early on, so that whether it is a sore on the foot, a cut on the foot, or whatever the first early stages are that might lead to amputation can be caught, treated, and the amputation avoided altogether. For people with diabetes, our diabetes self-management education focuses a great deal on foot care and foot exams, frequencies of those, and what to look for in order to immediately be able to see your doctor if something appears to be wrong. Now, I think there's always a need. There's certainly a need to be able to reach both providers and patients earlier in order to help avoid the problem, in order to help catch things early. I have a physical medicine and rehabilitation background, and I can say that the vast majority of people with diabetes whom I saw and who were on our inpatient, our hospital rehabilitation unit there, were there because they'd had an amputation, a toe or a foot or lower extremity amputation. And unfortunately, many of those toes went on to become a foot, and many of the feet went on to become a lower limb. What we did institute is a specialized program of patient education in those persons who'd had that initial amputation in order to start preventive care for the next amputations.
Yeah, the second question, thank you so much for that answer. The ADA has been tremendous in really helping the United States know the numbers about diabetes. And also the ADA has an academic wing, which has been tremendous in producing papers that help us all understand how diabetes is to be viewed and perhaps even cured. Is there any advice that the ADA can give? I mean, I'm a US doctor, but I work in the Caribbean quite a bit. Is there any advice that the ADA can give to the Caribbean on how to develop a way to capture the numbers and also to develop an academic part so that we can actually look at the problem and also perhaps develop solutions?
Right. That's excellent question. So without question, there is a need for the type of countrywide surveillance that's going to allow practitioners as well as patients and policymakers in the Caribbean know where their countries and populations stand. The ADA does not per se do the countrywide surveillance. The American Diabetes Association, for example, in the US partners with the Centers for Disease Control and Prevention, and that is the surveillance arm that captures the data that then allows us to be able to prioritize programming and education needs that the American Diabetes Association then carries out. I'd say similarly in the Caribbean, it may be that the Diabetes Association may not be the organization doing the countrywide surveillance, not to say that it could not. It may determine that it would like to take on that role. But if it's not the Diabetes Association, then what is the appropriate agency here who can do that type of surveillance? Certainly the Ministry of Health was responsible for doing the Pan American Health Organization's STEPS survey, but it could be that there are other public health partners in the Caribbean who may be the source of that type of surveillance. And without question, particularly as DAT and other diabetes associations start to think about their scientific reach and influence, I think the American Diabetes Association can be a nice model for how to do both the scientific and research arm, as well as an educational arm, and then advocacy and the patient support is the third arm. I think it might be a model that can be followed, but it's a challenge to do all these different types of functions, and so likely starting by prioritizing what next to grow within the organization would be the place to start.
Hi, Dr. Briggs. Nice to meet you. My name is Marianne Burnham. I'm from Barbados. As a follow-on question, in terms of that model that you were talking about, how do you propose we get it into the bits and pieces around the Caribbean? That health education model, because I find as a nutritionist myself, a lot of your average diabetic doesn't understand the condition. But when they get the health education, when they get that information, they're empowered and they can make a difference. The healthcare, receiving that healthcare information is different when they are empowered themselves, when they have that knowledge, etc. So how do you propose we get those health education programs done throughout the Caribbean? Yes, we do CME for the medical professionals, but of course we need to do the health education for the lay person. So how do you propose that we get that information out? How can the ADA assist? Because there are entities that are willing to do the work. So what do you think?
So first, I'll respond based not on the American Diabetes Association, but instead I think on some of what I learned while Johns Hopkins was here working with the Ministry of Health in diabetes a few years ago. During that time, one of our goals was to train other healthcare professionals, not just the physicians, but as you said, nurses. We actually trained some other types of professionals who were here in the country. There were coaches, health coaches, there were some therapists who completed formal training to become certified diabetes educators. The thinking was that we need people who are encountering patients with diabetes in many, many different sectors across the country to be able to deliver diabetes self-care education. I know that there are in some other countries as well training programs so that we can so that more people can be trained as certified diabetes educators and formally be responsible for that work. But there's also a role for lay people who want to provide their expertise as persons who have lived with the disease, taking care of others with the disease. What we have found, though, with regard to training lay persons is that it's very, very important to train them and certify them. They may not get the same certification as a nurse who now becomes a certified diabetes educator, but a very structured and comprehensive type of training that will allow them to provide the most up-to-date, accurate information while sharing from their personal experiences all that they have learned about how to cope, how to manage, how to persist, but ensuring that the laypersons get that same quality of medical information so that they don't inadvertently pass on experiences and learnings that are not accurate just from their own experience with diabetes.
Okay. Thank you.
No, thank you for those questions. So, Professor Hill-Briggs, we're going to get to the people because there are people on the street in Trinidad and they want to have answers. And they know almost every household has either one of two things, either a diabetic or hypertensive, but pressure and my sugar. And they want that fixed. And they want it fixed now. My patients don't want to take tablets, they want to take merengue. I don't even know what merengue is, but I'm learning, right? Now, what strategies can we employ here? And I know you've been here for a while. You've been down here since many, many times, and you're married to a Trinidadian. How can we go about educating our patients? What strategies and I've seen the 2017 guidelines, the ADA guidelines, strategies for educating the masses.
Yes. Right. So when diabetes is as prevalent as it is in Trinidad, I firmly believe it requires education on a mass level, on a public health level. So traditionally for diabetes, we do provide the education via either people's physician practices or, as I was just talking about, certified diabetes educators in a healthcare setting. Sometimes there may be programs out in communities. When there are this many people with diabetes and families affected by diabetes, I believe this needs to be on the billboards. It needs to be on the billboards.
I agree with you.
It needs to be on the radio. It needs to be on television because everyone can benefit. And I think one of the messages that's so important to pass on is that, particularly with type 2 diabetes, by making those behavioral changes, not only can you help your family member who has diabetes, but you can also help prevent or delay diabetes in other family members. If you're the family member who's worried about getting diabetes yourself in the future, the same messages that the person with diabetes is getting about how to eat healthier, how to get physical activity, they apply to you as well. And so I think it certainly is justified that this would be major messaging across the country.
And now we have some talented clinicians out here in the Caribbean. And that was as a rehab physician, and I know you have rehab physician, practitioner, provider in one of your check boxes of professions, because you had multiple careers. You were at Rusk, and you've been on physical medicine rehab faculty in the past. And not a lot of people know what that is. So I am glad you are here today with me to tell us about your experiences. How do we use, as a rehab professional and diabetes, how do those two intertwine? Because people always ask me, what does that have to do with diabetes and strokes? And what are your thought processes on that?
Right. So ironically, I got those same questions. So as a faculty member in physical medicine and rehabilitation, when I first arrived at Johns Hopkins and I was doing research in diabetes, I was asked the question, wait, what do those two things have to do with each other? But of course, you know well, the reason they are so intertwined is because people with diabetes do unfortunately suffer many complications of the disease that make them in need of rehabilitation services. And so in my instance, I encountered people with diabetes because they'd had an amputation or because they had kidney disease. We actually saw a lot of organ transplants, heart, kidney transplant patients due to diabetes. And so, and of course, the eyes and vision. So there are many reasons why a person with diabetes intersects with rehabilitation. What I wanted to see was rehabilitation go to people with diabetes before they
have that amputation.
That's right.
Yeah, I like that idea.
Yeah, I was sorry that that rehabilitation happens on the other end, because rehabilitation specialists can really work with patients on the preventive care.
Well, absolutely.
Let's get them on the front end so that we're not seeing them after they've had this first consequence. And of course, even after they've had a complication, we work very hard on preventing a next one. But we need rehabilitation before the first event.
Now, there's a crisis out here. Trinidad and Tobago has our healthcare crisis is the non-communicable diseases. However, our patients don't really care about non-communicable disease. They want to know my sugar and my pressure. They don't even know what non-communicable diseases are. But here's the thing. We are here to end this, and there isn't hopelessness here. We think we can fix this. I truly believe we can fix this. I don't know why. Call me naive, but I believe we can fix this. And within the next 5 years, we can have this arrow go all the way down, and we can drop the diabetes mortality rate to way surpass the United States and Canada's numbers. But so mark this date, November 12th, we're going to do Hands Across Trinidad and Tobago. We're going to hold hands across this country, and if you don't like the person next to you, hold a Trini flag, right? And we're going to know your numbers, and we're going to do it by the numbers, and we're going to encircle this country all the way around, and we're going to change this. So we can do this. So Professor Hill Briggs, we are truly honored. I've said this a million times, that you have accepted our invitation to be here and sit on this stage with me. I am honored to sit on this stage with you. Being a former military guy, we say honored a lot, we say thank you a lot, and we say yes ma'am a lot. So thank you from everyone in Trinidad and Tobago. I know you're coming out here serving us. So again, thank you for being here. Any final words?
Well, I just want to thank you first for inviting me here, but also for the work that you're doing. It is critical that we reach the population in Trinidad with diabetes, and you are here doing that. And so I'm grateful not only for this opportunity to talk with you and to meet you, but also for the work you're doing for the country. So thank you.
You're welcome. And we'll be right back on Ask Dr. Antoine.